everyone. Okay, so I'm doing Instagram and Facebook Live, so bear with me here, first time doing this. Welcome to the PT on Ice Daily Show. For those of you who have not met me, my name is Jessica Davis. I am the lead instructor for the Performing Arts Management course. I also instruct in the spine management courses as well. So today I wanted to spend some time talking about the low back, and I thought it would be nice to go over an interesting case that I had recently, just to help with a little bit of differential diagnosis. So let me tell you about my patient. So this is a 45-year-old female who came to me with a chief complaint of low back pain. Of course, she had, unfortunately, an MRI, which had shown degenerative changes in her lumbar spine. And her primary complaint was of central low back pain. Now, if you looked at the diagram, her own body diagram, she drew just a case of symptoms just across the low back. Hi, everybody. That was her body diagram. Now, we talk a lot about in ICE and how important it is to do our own body diagram. So I'm big on that. And so when I did my own body diagram and I cleared above and below the area of complaint, she mentioned to me casually, well, I do have a little bit of a chronic hamstring strain that I've been dealing with for years. So she sort of brushed it off. It wasn't one of her primary complaints, but she did report that it was there. But her main concern at the time was of having issues in the low back. So she's a CrossFit athlete, and her main concern was that she was having trouble doing squats and, of course, doing any kind of kipping or overhead press. Whenever she would do this, she would get intense low back pain. And once she saw her image, she had refrained from doing any CrossFit because she was afraid of damaging her back. So, of course, there was a lot of fear there. So let me tell you a little bit about as I observed her. So I did my own body diagram, as I talked about. She didn't have any symptoms distal to the proximal hamstring, no reports of numbness and tingling. She did have that central low back pain. The central low back pain could be independent of the proximal hamstring region, and the proximal hamstring region could be independent of the low back, but they could also coincide. Both symptoms were aggravated with forward bending, and she also reported symptoms when she would do her CrossFit moves. So, and again, no numbness or tingling, no bowel or bladder changes, nothing like that, no reports of weakness, just now she has fear of being an athlete, and she loves to do CrossFit on a daily basis, actually. So when I looked at her in standing, one of the unusual things that I observed, because we talk about how important it is to observe your patients before you do anything, obviously. So when I observed her in standing, her right lower extremity was everted. So she had an everted type posturing of the right lower extremity. Leg length appeared equal, increased lordosis in the lumbar spine, I noted, just at rest. So when I started observing movement, when she bent forward, she was instantly apprehensive, and she reported symptoms at 30 degrees of lumbar flexion, both in the hamstring and in the low back. And she was fearful of that movement. So I didn't push her there. Extension caused no symptoms, although I did observe excessive movement at L1, L2. So she sort of had obviously some hypermobility at that region, or I was suspicious that that was going on. And side bending, no pain either way. Rotation, no pain either way. So when I went into my exam and I looked at the hips, so we talk about how it's important. Of course, I did my overpressure, not in flexion, right? Because she already had symptoms in lumbar flexion, so there's no need for me to do overpressure with lumbar flexion. Extension with overpressure, side bending, quadrant, none of those reproduced her symptoms. So I get her into supine. Now I'm going to be doing my hip passive range of motion. What was very unusual with this patient was her left hip. Remember, I was telling you how it was everted. So when I took her left hip into flexion, she was fine. No reproduction of low back pain. External rotation was extremely limited. She had 25 degrees of hip external rotation. Hip internal rotation, 90 degrees. Now, I did overpressure in all of these planes and no reproduction of symptoms, but it was interesting. I thought it was interesting how she had such excessive hip internal rotation, and also the presentation of the hip resting in a degree of external rotation and standing. So I did my manual muscle testing. As I expected, she did have some core weakness. She did have proximal hip weakness. Abductors were fairly weak bilaterally. Hip extension, pain-free when I assessed the hamstring independently with manual resistance testing, both at flexion, 90 degrees of knee flexion and with 0 degrees, just at hip extension. No reproduction of her symptoms. So far, my only asterisk was lumbar flexion. Now, when I went further into her history, because we spent a lot of time in history, one of the things that she had also mentioned was she did experience pain with walking. And when I was specific about walking with her, she mentioned that it was the terminal stance phase of gait that would reproduce that buttock/hamstring. She referred to it as her hamstring, so I used her words, hamstring pain. So when you look further, so long story short, when I played around with my patient doing the squats, because I wanted to get her into functional positions and I wanted to see if I could ease her symptoms. So, I should go back. When I did my PIVM testing, so when I was looking at segmental mobility, she had a fair amount of mobility in her spine, okay? So she has a lot of movement. So kind of thinking there's some underlying instability that could be contributing to her low back complaints. But I'm still concerned or want to play with the hip, because even though I couldn't reproduce it passively, I still wanted to see it in the functional, in her primary functional report with squatting, and see if I could play with the hip. So historically, we'll see people do banded, either they'll do a lateral flexion, a lateral glide with a band with squats to see if that will relieve pain, or we'll also see that we're going to do the band and we pull posteriorly, so if they have that anterior hip impingement. In her case, when I took the band and I pulled anteriorly, so I was pulling her femur anteriorly with the band, and she did her squat, total resolution of symptoms, gone. So then I wanted to see, well, what happens if I take that anterior glide and I do that with combined lumbar flexion? Because I wanted to see if I play with the hip, am I able to get her low back pain to resolve? Because again, I'm trying to differentially diagnose, is this a lumbar complaint? Is this a hip complaint? Or is it both? I'm suspicious it's both, right? So when I did that anterior glide to the hip with combined lumbar flexion, resolution of pain. So full pain-free lumbar flexion with addressing the hip. So now on my problem list, my hypothesis list, at least where I want to go to in treatment that day, was I wanted to treat the hip. So I know she has some weak hip external rotators. She has some weak hip abduction. But I also know there's something with this, she responds very well to an anterior glide. So when I looked at the literature, and one of the things I want to talk about today, which is why I said this is a curious report, is something that a hip issue that you can see that isn't very common, but it exists, is called ischiofemoral impingement. So I have some nice articles that I wanted to go over about this because she tested pretty positively. So there's a nice article that was published in the Journal of Hip Preservation Surgery in 2015 talking about deep gluteal syndrome. And what I like about this article is it goes into a nice differential diagnosis of buttock pain, proximal hamstring pain, and kind of helping you differentially diagnose. So some of the things that should be on our hypothesis list are pudendal nerve entrapment, ischiofemoral impingement, greater trochanter ischial impingement, and ischial tunnel syndrome. So one of the tests that it mentions is for ischiofemoral impingement to be positive, you have to have sciatic nerve complaints. She didn't have that though, so I will say that. Lower back pain and limping is also on the history. So any of those three in the history, you should put that in the hypothesis list. She didn't mention low back pain, right? For the physical exam, what they mention is long stride. So again, that terminal stance with gait, when you do the long stride, they're going to report pain at that end range of hip extension. That's exactly what she reported. Tenderness along the lateral ischium and positive ischiofemoral impingement test. So I want to talk to you about that. So of course, the gold standard for this is an MRI. So the MRI is going to confirm that there's this impingement. So we're going to go into that in a little bit. So another wonderful article that was also published in the Journal of Hip Preservation Surgery. This one was published in 2017. It talks about specifically how to address ischiofemoral impingement. and it has a nice algorithm for treatment. And this is a review of the literature. So it's a great article. So it talks about that the symptoms, again, it repeats, are in the lower buttock. They're going to be with standing, that terminal stance, and they can report in some cases some snapping or clicking. She didn't report that, but also low back pain. They say that it is, in terms of the current literature that's available for conservative management, there's very limited evidence currently out there aside from case studies. So keep that with a grain of salt. That's just what we have right now. So the definition of ischiofemoral impingement is a narrowing of the space of the os ischium and the lesser trochanter of the femur. But what it is it's an entrapment of the soft tissue in that region, okay? And specifically, the quadratus femoris muscle is being entrapped between those two osseous structures. Okay, so one of the things that can cause this, they talk about, it can be a derivative of a previous hip replacement surgery. Also, it could be congenital. Now, when I went into her history, she did casually mention, oh yes, when I was little, I had to have bracing because I had hip dysplasia. So that explains what was going on with the hip, because it was very unusual in its presentation. So she, and this is one of the things that they cite, is developmental dysplasia of the hip can be a cause of this ischiofemoral impingement. So clinical symptoms are going to be load dependent. So this is exactly what she's talking about. Walking, squatting, when she's doing CrossFit loading. So that's when she's experiencing this. So they talk about specific tests in this article again, and they mention the long stride test. The long stride test means putting the patient into that walking stance and seeing if when they're in that end range terminal stance phase of gait, if that reproduces their exact complaint. They said the sensitivity of this test is 92% and specificity 82%. The second test they mentioned is that ischiofemoral impingement test with a sensitivity of 82% and specificity of 85%. So I want to describe this test to you. Unfortunately, I don't have a patient today. I begged and pleaded everybody to be a body for me to show this test to you, but I couldn't get anyone. So you put your patient inside lying. You're going to abduct their leg, and what you want to do is bring their hip into abduction and extension and a degree of internal rotation. So think about, I'm going to try to demonstrate this. So they're about here, and you're going to extend their hip. Let me see if I can lower this camera a little bit for you guys. Okay, so you're going to extend their hip, and you're going to bring them back with a little bit of adduction and internal rotation. They will report in this test, that's my pain, right? So we're always looking for, that is my exact complaint. She tested positive. Now, to be a true positive test is you take them into further abduction, external rotation, and extend, and the symptoms go away. So you're impinging with the first position, and you're taking that impingement away by doing a little bit of external rotation and abduction. So I would look up the ischiofemoral impingement test for you guys to see this, to know specifically what I'm talking about. So again, she tested extremely positive for this. So I knew in my treatment that I needed to work with that with her. So going farther here, what I love about this is they talk about therapy. So they say that what you should address in therapy, and again, this is a review of the literature, is address the impairments. Excuse me. And the beauty of this is they say that most of these cases respond extremely well. Now, mind you, this is the hip preservation surgery that's saying that these patients respond extremely well to conservative management. Address the impairments. We always talk about at ICE, look for your impairment list, look for your asterisks, test, retest, right? So I knew she had impairments, so I knew what to work with. And what they say is you give 3 months of conservative management of these patients, and if they're not doing well, then they suggest considering surgery. So they don't even encourage surgery. They encourage conservative management of these cases. So I want to tell you how I treated her. So I knew that anterior glide in the squat and load position was very helpful. So of course, I gave that to her for a home program, right? I had her use the rock band. I put that on there and I told her, load the heck out of this. Go back to the CrossFit gym. Don't be afraid of your back anymore. So she was very excited, of course. Manually, what I did was I did an anterior glide mobilization, right? So I knew she was limited in external rotation. I wanted to get that mobility back. So I've got her prone. I'm doing my anterior hip glides. Lo and behold, forward flexion of lumbar spine improved dramatically after doing that test retest. And so in treatment, I'm teaching her those self kind of glides, right? And then strengthening, I knew she was weak in hip external rotation as well as abduction. So I'm going to work on standing functional hip exercises, right? Standing at the wall, activating the glute med, getting her loading and working these positions and getting her out of the fear that she has a low back problem. So I hope this helped, because what I want to emphasize here is if I had, first of all, ignored the body diagram and cleared that aspect of the hamstring, then she would not have reported that to me, because in her perception, thanks Bill, in her perception, she would think that it wasn't an issue and not mention it to me, right? You got to ask, you got to clear it. Then you've got to look at the test retest. So I knew that her primary complaint was the low back. I wasn't reproducing it aside from lumbar flexion. I had to clear the hip. We know clearing the hip with overpressure, but something was unusual with this case, so I had to dive further. So I hope that I got this patient better in a few visits. She's doing extremely well. She's back in the CrossFit gym. But if I had just looked at her low back and not addressed the hip issue and not explored further into the why, then I wouldn't have gotten her better. So anyway, I hope everybody has a great day. Happy Tuesday. And also, don't forget, this weekend is the Ice Sampler in Vegas. I can't wait. I'm super excited. It's good. Everybody's going to be there. So if you don't have a ticket, and just come to Vegas. You can find a cheap flight to Vegas. It's fun. Come to class and hang out with all of us. Okay. Have a wonderful Tuesday, everybody. Thank you for listening. Take care.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.